Namaskar. Designing anti-hairline in male, temporal fringe, parietal hump. My talk has three parts. Part 1, reconstruction of anti-hairline. Then part 2 is reconstruction of temporal fringe and the line, and the reconstruction of the parietal hump. Why do we need hair transplant? To reframe the facial boundaries, as the beauty lies in the proportion of one body part to the another. This man's face looks aesthetic because proportion of his face is maintained. During AGA, the anti-hairline recedes, forehead widens, and this alters the facial proportion, compromising the facial aesthetic. So, the hair transplant surgeon shall relocate anti-hairline to maintain back the facial proportion. Anti-hairline maintains the vertical framing of the face, while the temporal area maintains the horizontal framing of the face. Now, the designing of the male anti-hairline. The facts of anti-hairline. The designing of hairline is fusion of art and the science. Designing of hairline is the key for successful looking hair transplant. Anti-hairline is not a line, rather it's anti-hairline zone consisting of macro irregularities, micro irregularities, transition zone, and a high density defined zone. Anti-hairline is designed in a way that it not only fulfills the present demand but also suitable for the patient's future appearance. The reconstructed hairline should be natural looking with enough density. The hairline differentiates the scalp from the face and maintains the aesthetic proportion of the face. During AGA, the anti-hairline recedes, altering the facial proportion, leading to compromised aesthetics of the face. The reconstructed hairline restores the facial proportion. The factors to be considered for hairline design are the age of the patient. The age of the patient is of prime importance. In patterned hair loss, hairline recedes with advancing age. This factor should be kept in mind while planning is done in young patient. A more demanding young patient needs detailed counseling and also the exclusion of for body dysmorphic disorder. The hair characteristics, the hair follicles per follicle unit, diameter of hair shaft, color, and the curvature of the hair needs to be taken in account while reconstructing anti-hairline. A natural hairline has a softer look with local skin color match and a gradual transition of hair density from ill-defined zone to well-defined denser zone. Coarser, thicker hair implantation in anti-hairline will give a hard look. Similarly, multiple follicle unit in anti-hairline will give unnatural look. Less contrast provides better visual density. In higher contrast, the scalp shows through more, meaning less visual density. Natural curvature or the curling enhances the visual impact of the density. Facial features. In natural anti-hairline matches facial aesthetics. The broad, flat forehead will have a more flat hairline, but a narrow head will need a less flat or oval hairline. So, all facial aesthetics means the curvatures should be transformed in reconstructed hairline to give a custom-made hairline. Sex. The male pattern baldness shows a natural receding, while in female pattern hair loss, anti-hairline remains intact. A female forehead is narrower and a more anteriorly placed hairline and a round frontotemporal angle, but in male has a well-defined frontotemporal angle. Deep triangular frontotemporal receding is because of hair loss in this area and is a feature of male pattern hair loss. Ethnicity. There is a change in the anti-hairline as per the ethnicity. The Black, Asian, and Hispanics have a broad, flatter hairline. So, the ethnicity of patient is an important consideration while reconstructing anti-hairline. The profession of the patient. The celebrities like film star and those who are doing the modeling need a relatively young-looking, high-density anti-hairline. The family history of baldness, the younger patient with family history of baldness are likely to develop higher grade of baldness in future. So the donor preservation for future coverage shall be kept in mind. The donor reserve, the recipient area planning of present baldness shall be done keeping in mind of donor hair follicle reserve and expectant future increase in baldness requiring the donor follicles. Patient preference, it is a common demand for lower hairline as they had at teenage. This is more common in younger patients, so we need to explain the patient about the limitation of donor supply and possibility of future requirement. The surgeon shall make a balance between patient preference, science and aesthetics of hairline and future facial changes. The factors for the anti-hairline: location of hairline, shape of hairline, natural looking hairline and zones of hairline. The shape of hairline, the aesthetic curvature of forehead shall be transformed in the shape of hairline as I mentioned before. The most common shapes are triangular, oval, flat and crescent. Flat forehead will have a flatter hairline and a curved forehead will have a deeper hairline. Round forehead will have a rounded hairline. Shape of hairline depends on ethnicity also. The typical East Asian has a round skull, while average Caucasian male have a ovoid skull shape. Afro-Caribbean men exhibit a relatively low placed straight hairline that meets temporal line in a rectangular shape manner. This is the oval hairline, this is the round hairline, this is a triangular hairline, and this is a straight, square or a flat hairline. Now, the anti-hairline gets receded during AGA and we need to reposition hairline in a way it looks natural, and this was done in this case. Location of hairline, the most common demand by patient is a hairline that they had in their teenage years. In such circumstances, the surgeon should try to explain the following aspect to the patient. The hairline should be appropriate for the age. With advancing age, the facial features change and receding of anti-hairline to a higher level is expected. The level of anti-hairline should be planned accordingly. The possibility of progressive hair loss over the remaining frontal and the mid-scalp region might give anti-hairline an unnatural look if anti-hairline was placed at a lower level. Anti-hairline placed low on the vertical part of the forehead generally consumes many more graft of hairline alone to provide a natural look. This may hamper optimum availability of graft to the other balding region. The high place hairline can be lowered in the future, but a low place hairline is difficult to correct. So the criteria for the location of hairline is, the most commonly is, it is the junction of horizontal and vertical. Second is 7 to 10 centimeter from the glabella. Another is the forefinger from the glabella and above the superior transverse frown line. This is a case of advanced grade of baldness with limited donor supply and advanced grade of patient. The midfrontal point was planted at 8 cm from the glabella and he looks quite natural. Another case of advanced grade of baldness with moderate donor supply and a younger patient. The midfrontal point was planted at 7.5 cm. He looks quite good. Now the frontotemporal angle or a point. The angle between the frontal hairline and the temporal line is called as the frontotemporal angle, and where the both line meets is the point. The frontotemporal point is the placement of frontotemporal point is crucial for aesthetic reconstruction of hairline. There are 3 important criteria for the placement of frontotemporal point. One criteria is the frontotemporal point shall be at the level and or just above the mid-frontal point. The criteria 2 is the frontotemporal point should be in the line of lateral canthus line. The criteria 3rd, yes. For this, let's understand few important landmarks to guide the placement of frontotemporal point. This is the frontotemporal point, this is lateral canthus, this is angle of mandible, this is the side bone, this is the anterior border of the side bone, This is posterior border of the sideburn and a point anterior to the tragus. Now, this is the superior border of the temporal fringe. The FTP should be at the junction of, means FTP is basically placed at the transection of the two lines. One line is the lateral canthus line, as we explained before. Second line is a vertical line passing from preauricular area, but it has three variations depending on the grade of baldness and the donor supply. Condition 1. The mild grade with good donor supply, the vertical line passes anterior to the sideburn. This is the yellow line I am showing here. The moderate grade with adequate donor, vertical line should pass posterior to the sideburn. I am showing here a dotted red line. Then severe grade of baldness with poor donor supply, the vertical line should pass anterior to the tragus. This I am showing a blue line. So these are the three lines marked at different level depending on the grade of baldness and the donor supply. Now, to relocate the frontotemporal point, midfrontal point and the temporal point during AGA, all these 3 points recedes in same proportion. So, advancement of all three important landmarks are placed in same proportion in which they have receded, following all the aesthetic criteria which I explained you before. So let's see, this is FTP, TP and midfrontal point. We need to advance this, so they should be advanced in the same proportion. This was done here in this case. This was done here in this case. Oh, this is obtuse frontotemporal angle. Frontotemporal point is lower than the midfrontal point. What happened? Let's understand. Oh, this was the receded anterior line. It was needed. The advancement was needed in this case. Very common patient what obtuse anterior line, because during childhood he had and the surgeon did this. It should be advanced in the same proportion as it was receded, as I explained you before. So it should not be done. A very common demand of low hairline and a obtuse frontotemporal angle. This can be done by creating a graph economical illusion by creation of a widow's peak and advancement of anterior temporal line medially. This was done here, and this is the case I am showing here. Widow's peak creation, this creates illusion of low anterior hairline. Now third is the making anterior line natural looking. Anterior line should look natural. The internal divisions are frontal tuft area, which is denser, defined zone and a transition zone. Transition zone has a cluster or the macro irregularities, a random hair or the micro irregularities. This makes the hairline more natural. This you can see, these are the random hair and these are the clusters, and they are the gaps, clusters and the sentinel hair. This is a perfect natural looking hairline. This is a natural looking hairline. Oh, what has gone? Let's understand. If you understand this, then you will not commit the mistake. Let's understand. So here what has done? Frontotemporal point is lower than the midfrontal point. The anterior line looks straight. The multifollicular unit has been implanted in the anterior line, and the curl and the direction of hair are in different direction. These all has made the anterior line unnatural. So it should not be done. Now the temporal fringe or the triangle. This is the classification of temporal hair loss in the temporal fringe area. This is the class 1 where there is no receding, no thinning. Then class T, there is a thinning but TP is maintained. Here is the class P, temporal line becomes parallel to the sideburn. This needs the reconstruction. Class R, the temporal line becomes C-shaped, means reverse. This again needs the reconstruction of temporal fringe. So the Mayer's guideline for placement of temporal point. As per Mayer's guideline, the temporal point is a point of intersection of two imaginary lines drawn as follows. Line 1 is from the tip of ear lobe to the mid-frontal point. This is line 1. Then line 2 is from the base of the nose to the center of the pupil. So these are the two lines. Then the temporal peak point is the intersection of these two imaginary lines, and here this yellow triangle is your TP. Now the distance between the TP and mid-frontal point shall be less than 3 cm as they are in proportion, as I said you before. So there is a strong relation between TP and mid-frontal point when they recede. So when you relocate them, you should maintain the same proportion. Here is the mid-frontal point and TP point. Here is the line. The distance should be less than 3 cm. If you put mid-frontal point lower than desired, then the distance between TP and mid-frontal point will be more than 3 cm. And if you place TP more posteriorly, again the distance will be more. So this was the more 3 cm. So it will look unnatural. Now these are the temporal point. This is the usual direction of temporal hair are in upper area. They are slightly downward, slightly forward. In lower area, post-auricular downward and backward facing to the ear. The angle of hair in this area should be kept as flat as possible, 0 to 5 degree, and single or the two hair follicle grafts are used to graft the temporal area, and the existing hair helps to determine the direction of graft implantation. The usual density approximately is 20 to 25 grafts per square centimeter. This is the temporal fringe reconstruction. This is the normal TP but receded temporal fringe. So we reconstructed this and it looks quite natural. This is a conservative reconstruction with limited donor supply in this area. Here the low density temporal fringe has been reconstructed because of the limited donor supply. This is a reasonable density has been given in this case. Now the parietal hump creation. This is the part 3. In a more severe degree of hair loss, when temporal hair has receded and lateral fringe has dropped, in such case, there is a need to reconstruct the lateral or the parietal hump. The lateral hump is a semicircular area of hair that is located superior to the ear and bridges the lateral fringe to the mid-scalp region. This is a temporoparietal fringe. The new lateral hump is shown here as a yellow line. The newly reconstructed lateral hump will give a lateral epicanthus line to intersect. Here is I am showing here. This is very important to understand. Parietal hump is needed. Why do we need parietal hump creation? Parietal hump is needed to relocate frontotemporal point. So a natural anterior line can be reconstructed. As I said before, if we mark frontotemporal point over the receded or the dropped parietal hump as it is shown here, then the FTP will be at a lower level to MTP, which will make an unnatural look. Here is the midfrontal point. We have marked frontotemporal point over the receded parietal hump. So here the FTP will be lower than the midfrontal point and the anterior line will have frontotemporal angle be obtuse or a round, which will look unnatural in a male. So the FTP should be placed over a reconstructed parietal hump. Now, how to decide the height of parietal hump? The height of parietal hump will depend on the location of midfrontal point, means higher than the midfrontal point or at the same level, as I explained before. So now let's understand step by step. I need to place a frontotemporal point. So by question up, down, front or back, how to decide this? Step 1 is to relocate a point. We need 3 lines or the 3 planes because we are relocating a point in 3 dimensions. And for 3 dimensions, you need 3 lines to intersect. First we knew is first line, the plane is FTP should be at the level or just above the midfrontal points as I am showing here. Then the second is the line is the plane. Vertical line passes anterior to the tragus as it has got a higher grade of baldness with limited supply. So the vertical line passes anterior to the tragus. I explained you before. Now the third line is the FTP should be at a vertical line of lateral canthus, as I explained you before that this line in the vertical canthus line. If you draw these 3 lines, it will be placed at a natural angle. That's how it has been done here, and this has been reconstructed here. Now let's understand this case again. and he looks quite natural. This is a case before and after. This is case before and after. These are my reference. So thank you very much.